Sabah al-Khair. I'm honored to be here. This is the Arch in St. Louis. I'm jealous from all my colleagues who are speaking about their accomplishments. I represent my complications. My talk is divided in 10 points. The last are case scenarios that bring painful memories. Access site complications are the most common iatrogenic injuries, and I don't want this to consume most of the talk. But of course, bleeding, pseudoaneurysms, AV fistulas are well tolerated. Pseudoaneurysms are treated by injection, occlusions, occasionally closure device complications, and compartment syndrome with the new access from brachials or pedal access. Second one is dissection. If you have a dissection at the access site and you identify that, well, stop and try something else. Remember that there is a left femoral artery that is not violated by your cardiologist. The long nose of closure devices are long and they can reach the aortic bifurcation and cause dissection. Avoid oversizing of balloons. Do not inject if you cannot aspirate. Dissections are usually well tolerated if they are less than 30%. Do not lose wire access after balloon angioplasty. Treat minor dissections with prolonged inflations. Confirm we are in the true lumen distally before any intervention. Site of re-entry need to be tacked like any surgical principle or atherectomy. If you cannot re-enter in a true lumen, pull back and try to find another plane. Do not extend beyond 1 to 2 centimeters from the re-entry reconstitution. Use re-entry devices or pedal access when necessary. A dissection in a T-car, just a point of worth mentioning here. If you identify it as the stage of wire dissection, do not try too much. Stop, and in my limited experience with 2 cases, go from the groin, it's already prepped, and do transfemoral stent. If you already did intervention in subintimal plane, it's a bad day, probably carotid endarterectomy. Embolization. Avoid air, of course, in the carotids and the mesentery. A carotid sheath should not be flushed inside the patient. You need to pull it out. Do not advance the sheath without introducer, because snow plowing. Beware of easy crossable lesions. It might not be that you're good. It might be all thrombus. Beware of the long occluded stents. This is a picture of embolization. That's not my case. Treatment, aspiration, suction thrombectomy, mechanical thrombectomy, and of course, open thrombectomy is available to us as surgeons. Embolic protection devices, I'm liberal in using them, especially encouraged in large volume burden of clots, of plaque, occluded stents, suspicion of acute thrombus, single vessel runoff in atherectomies, and always in the carotid. Watch the filter position, and it might get stuck in the distal end of the lesion, and you might have, if that happens, you must have to pass a wire next to the filter and stent over it, and usually in an unfavorable location for stenting. In a transcarotid femoral artery stenting, make sure that the sheath is stable with good purchase, because the worst scenario is the sheath pulls out with the filter deployed through a lesion or through a deployed stent. Embolization of devices. Can this happen? Yes. Rare, it's becoming more rare than ever with the newer devices. The stents, if it's not balloon mounted, it can balloon seed. The wires can be sheared. Endo anchors, we've lost endo anchors and endografts, and we were able to suction them through a big sheath more than once. Mal-deployed coils, new NOR coils, I do not detach. They are easily controlled. So let's happen. Venous embolization. Many people have pictures like this of limbs of IVC filters in the lung. Perforations. A perforation with a wire, if it's detected, it's not a big deal. You either stop, come another day, try to get in a true lumen, try pedal access. With the issue that to identify it earlier, not to put a catheter and inject through the catheter or do intervention. This is also my case. It's published. Our early experience with atherectomies. 𝗘𝗴𝘆𝗺 pseudoaneurysm treated with a covered stent. This is not mine, but it's a perforations from wire perforations in the renal artery. If unstable, you can coil it. If it's stable, you can leave it. Rupture of vessels. There are vessels that are notorious for rupturing. The external iliac artery above the inguinal ligament, that's not mine, but this is mine. 𝗙 at the end of the case, blood pressure falls to 0. You have this extravasation, a wire is still there, a balloon, controlled with balloon, covered with a covered stent, still the patient hypotensive, and I opened. The tip here is don't pull the sheath and the wire together at the end of the case. Pull the sheath, leave the wire, make sure that the A-line, the pressure is okay, make sure anesthesia are not checking ACTs or flushing A-lines, and then take a picture of the external iliac before you get out. Technical device malfunction. Many things can go bad, including kinking of a sheath across the bifurcation, closure devices, a atherectomy device gets stuck in a stent. 𝗘𝗴𝘆𝗺, by the way, is contraindicated in stents. Laser can overheat and occlude the stent. Re-entry device can get stuck. An 𝗙 unibody one time got stuck in a limb and had to convert to open. Late failures. This is a fracture of a stent I placed transfemorally in a patient who fell off a ladder, and the other carotid was occluded, and we re-stented the stent. IVC filter. This is at time of retrieval. You see a limb already free and limbs out, filter successfully retrieved. Coverage of branches. It happens to the best of us. Renal arteries can get covered during EVARs. There is nothing preventing these devices from going north. So always make sure it's anchored when you're putting the contralateral limb. You can try to bring it down a millimeter or two. If it's covered, then you can snorkel in site of fenestration or convert to open. The retained devices. This is also my case. It's a sheared wire at an axis for a FEMPOP that's occluded. And it's outside the circulation, it's left. A sheared balloon one time from an AV graft balloon, completely separated and embolized in the pulmonary artery on the other side, could not retrieve it. It was no problem, didn't cause problems. During the transfemoral carotid artery stenting, you might have a difficulty putting a retrieval device up or catch the bottom of the stent. If that happens, the tip I give is that you inflate a balloon inside the stent, advance the sheath over the balloon while you're deflating it into the stent, and then advance the retrieval device. Bailout equipment. You should have some bailout equipment in the area to do endovascular. Aspiration catheters, mechanical thrombectomy devices, cover stents, coils, and different sizes of snares. Snares, one time, more than once, we had stents that are loose inside the body. If they are on a wire, you can put a balloon on it, you can snare it and advance the balloon in it and deploy it somewhere else, like in the iliacs. Nitroglycerin, coils of different sizes, snares of different sizes, at least 2 sizes, one for the SFA and one for iliacs. These are coiled. This is mechanical thrombectomy. In conclusion, injuries occur less with experience. Injuries occur less with improved imaging. Anticipate complications and have a plan to deal with them. Reporting of device failures, example, the MODA website in the US. Be familiar with bailout procedures. Vascular surgery is a privilege that we can go in and do open cases. Do not let these complications hold you down. Just get better. Thank you.